Welcome to the deep dive. Ever wondered about that specific kind of knee pain that seems to pop up in active teenagers?
Yeah, that one just below the kneecap.
Exactly. Today, we're going to decode Osgood-Schlatter's disease. Think of it as getting the real story on that nagging knee issue.
And this deep dive is really for you, the learner. Maybe you're a parent, an athlete yourself, or just, curious about this pretty common condition. We'll cut through the jargon.
Get right to the core stuff. We'll explore what it is, why it seems to happen, who gets it most often, how doctors figure it out, and importantly, what can be done about it.
And we got a few memory tips scattered in there too, hopefully, to help it all stick.
Yeah, absolutely. Our goal is for you to walk away feeling you've got a good handle on Osgood-Schlatter's without feeling, totally overloaded.
Yeah.
So let's kick things off. What exactly is Osgood-Schlatter's?
Okay, so in simple terms, Osgood-Schlatter's disease is basically an inflammation and irritation of the growth plate right at the tibial tuberosity.
Tibial tuberosity, that bony lump just below the kneecap, right? You can feel it quite easily.
That's the one. And the key group we're talking about here is adolescents, especially during those really rapid growth spurts, and particularly if they're very physically active at the same time.
Ah, okay, so it's that combination growing fast and being really active.
I can't say. It's very common in young people, particularly kids involved in sports that, involve a lot of repetitive use of the knee joint. Things like running, jumping.
Got it. Okay, we've defined it. Now let's get into the why. What are the sort of underlying factors here? What leads to it?
Well, this is where it gets a little maybe less clear-cut, the exact cause. It's still a bit of a mystery, actually.
Really? Okay.
But the leading theory, the one that makes the most sense, revolves around repetitive stress and tension, right on that tibial tuberosity growth plate.
Repetitive stress that fits with the active teens picture. What kinds of activities are we talking about? What puts the strain there?
Think about movements that really load the knee. So jumping is a big one. Running. Sports that involve lots of sudden stops or changes in direction.
Like basketball, football.
Exactly. Football, basketball, gymnastics, volleyball. Those come up a lot. And like we said, it's much more common in kids playing sports, especially during those growth spurts. It's almost like the bones are growing faster than the tendons can keep up, creating extra pull.
That paints a really clear picture of that mismatch. So who's most likely to get this? Are there specific risk factors we can point to?
Yeah, definitely. We could identify several key things. One is being male. There's a higher incidence in boys
Interesting.
than, as we've discussed, playing sports with lots of running, jumping, or frequent knee bending. That's a big one. And of course, just being in an adolescent growth spurt phase is a major factor.
Right. So that image of a teenage boy maybe playing basketball, shooting up in height, that really fits the profile.
It really does. But there can be other contributing factors too.
Oh, like what?
Things like muscle tightness, especially in the quads, the big muscles at the front of the thigh. That can increase the tension on the tendon.
Okay.
Also, imbalances in strength, say between the quads and the hamstrings, and maybe even certain individual anatomical factors, just how someone's knee is built, could play a small part.
Okay, that makes sense. We know who's at risk, what might trigger it. Let's dive a bit deeper into the biology. What's actually happening in the knee, the pathophysiology.
Right. So it all starts with that repetitive stress on the growth plate of the tibial tuberosity. The constant pulling from the patellar tendon where it attaches, well, it leads to tiny little microfractures.
Microfractures, wow, like tiny cracks.
Exactly. And inflammation. Think of it like constantly tugging on a point that's still developing and, frankly, a bit vulnerable. Eventually, it's going to get irritated.
Yeah, you can see how that would cause pain, especially for someone trying to be active.
Definitely. And here's a really key point. During those rapid growth phases, bones often lengthen faster than the muscles and tendons attached to them.
The mismatch again.
Yes. So this difference creates even more tension in that patellar tendon. It pulls harder on the tibial tuberosity, and all that mechanical stress results in the inflammation and pain right at that spot.
So the tendon is under constant strain, pulling on a part of the bone that's still kind of soft because it's growing?
You've got it. That's why active adolescents are the prime candidates. Every time they contract their powerful quad muscles, like when running or jumping, it just amplifies that force. It can even cause tiny little avulsion fractures.
Avulsion, meaning it pulls tiny bits of bone away.
Yeah, small fragments get pulled away from the main growth plate area. And this typically happens right during that peak growth spurt, before the tibial tuberosity fully hardens up or ossifies.
And what happens over time? Does the body try to fix these little injuries?
It does. As these microfractures heal, the body lays down new bone. This repair process can actually lead to the tibial tubercle getting bigger, becoming enlarged.
Ah, so that's the bump people talk about.
That's often the bump, yes. And how big it gets varies a lot between people. But that bony overgrowth can sometimes remain even after the pain settles down.
Okay, really clear explanation of the process. Now, shifting gears slightly, if someone comes in with this kind of knee pain, how do doctors make sure it is Osgood-Schlatter's and not something else? What about differential diagnosis?
Yeah, that's crucial. You always have to consider other things that could cause pain in that area. It's about ruling them out. For instance, there's patellar tendonitis. It's often called jumper's knee.
Jumper's knee, right. Heard of that one. How's it different?
The inflammation is mainly in the patellar tendon itself, usually a bit higher up than the tibial tuberosity where Osgood-Schlatter's is focused.
Okay. What else is on the list?
Well, there's patellofemoral pain syndrome, sometimes called runner's knee. Is that more pain sort of around or behind the kneecap?
Another sporty name.
Yeah. Then you've got to think about stress fractures in the tibia or femur nearby. Bursitis inflammation of those little fluid-filled sacs around the knee, even injuries inside the joint, like meniscus tears or ligament sprains, although they often present differently.
Wow, quite a few possibilities just around the knee.
Definitely. And we also need to consider an actual tibial tuberosity fracture, a bigger break than the microfractures we talked about. There's osteochondritis dissecans, which is a cartilage and bone issue, and another one called Sinding-Larsen-Johansson disease.
Sinding-Larsen.
Johansson, yeah. It's quite similar to Osgood-Schlatter's, but it affects the bottom tip of the kneecap, the patella itself, rather than the tibial tuberosity below it. So it's really about pinpointing the pain location, understanding what makes it worse, and the physical exam findings.
Sounds like careful detective work. Okay, let's talk numbers. How common is Osgood-Schlatter's, especially thinking about the UK?
Yeah, here in the UK, it's definitely a common thing we see in young athletes going through puberty. The estimates vary a bit, but some suggest around 20% of adolescents in the UK who are active in sports might experience it.
20%? That's actually quite high, like 1 in 5 sporty teenagers.
Roughly, yeah. It's significant. And age-wise, it typically hits boys between about 12 and 15 years old. Girls tend to get it a bit earlier, maybe between 8 and 12.
And you mentioned it's more common in boys.
Yes, we do see it more often in boys. And those sports we mentioned, football, basketball, gymnastics, volleyball, they can consistently pop up as being associated with it.
Makes sense given the repetitive jumping and running in those.
Exactly. The demands just place that repeated stress right on the tibial tuberosity.
Okay, so let's say a parent or a young person suspects this might be the issue. What are the absolute key signs and symptoms? What should they be looking out for?
Okay, the absolute hallmarks are pain and swelling, specifically located right at the tibial tuberosity that bump below the kneecap.
Right there, okay.
And a really crucial clue is that the pain gets worse with activities involving the knee. Running, jumping, squatting, even just kneeling directly on it can be quite sore.
But it gets better with rest.
Usually, yes.
Yeah.
Rest tends to ease the pain. Often the area will be tender if you press on it, and you might actually see or feel a noticeable lump or bump developing there over time.
Pain with activity, relief with rest, localized tenderness, maybe a bump. That seems pretty specific. So what would a doctor focus on during an examination?
Well, they'll start by taking a really detailed history, asking about the pain, exactly where it is, what makes it worse. They'll specifically ask about knee extension activities, running, kicking, jumping, stairs, squatting, and does rest help?
Got it. And the physical exam?
On examination, they'll look closely for any swelling or redness around the patellar tendon or right over the tibial tuberosity. Then they'll gently press, palpate that area and the tendon itself to check for tenderness. They'll also assess how prominent that tibial tubercle feels. And a key test is often having the patient try to straighten their leg against some resistance. Pain with that action really points toward the diagnosis because it engages the quads and pulls on that insertion point.
Ah, that resistance test makes total sense. And you mentioned checking the hip earlier. Remind us why that's important.
Yes, absolutely vital point, especially with knee pain in this age group. Always, always check the hip. Some childhood hip problems, like a condition called slipped capital femoral epiphysis or Perthes disease, can actually present as knee pain. It's called referred pain.
So the problem's in the hip, but they feel it in the knee.
Exactly. So a thorough knee exam in an adolescent has to include a hip examination to make sure we're not missing something originating there.
Good clinical pearl. Okay, so with this history and these exam findings, are investigations like X-rays always needed? Or is the clinical picture usually enough?
In most cases, a confident diagnosis of Osgood-Schlatters can be made just based on that classic history and the physical exam findings. If everything fits the typical picture, X-rays aren't always necessary right at the start.
Okay. So when would you think about getting an X-ray?
Well, there are a few situations. If the diagnosis isn't completely clear from the clinical assessment, maybe something feels a bit off. Or if the symptoms aren't getting better like you'd expect with the initial treatment, like rest and activity modification.
Right, if it's lingering.
Exactly. Or sometimes maybe just to track how things are progressing over a longer period, X-rays might be considered then.
And if you do get an X-ray, what might you actually see?
In the early stages, maybe not much, perhaps just some soft tissue swelling around the tibial tuberosity area.
Okay.
Later on, though, the findings can be more specific. You might see that the tibial tuberosity looks enlarged, or it might look irregular, maybe fragmented like the bone formation isn't smooth. Sometimes you could even see a separate little piece of bone, an ossicle, within the tendon near where it attaches.
Interesting. So the X-ray can show those structural changes from the repeated stress and healing. Are there specific red flags or situations where an X-ray would be ordered sooner rather than later?
Yeah, definitely. If the symptoms are only on one side, unilateral, sometimes that warrants a closer look to rule out other things.
Ah,
Also, if the pain is really severe, like debilitating or just not responding at all to simple measures, persistent pain is another reason.
okay.
And of course, if there was a specific injury, like a direct blow to the knee, you'd want an X-ray to check for an acute fracture.
Makes sense. What about fancier imaging, like ultrasound or MRI? Do they ever play a role?
It's much less common for typical Osgood-Schlatters. They're usually reserved for situations where you're trying to rule out something else, maybe something more serious.
Like what?
For instance, if there's a real concern about a bone infection, osteomyelitis, or maybe even a tumor, though that's rare, MRI gives really detailed pictures of bone and soft tissue. But for your average case of Osgood-Schlatters, they're generally not needed.
Right. So, key takeaway. Clinical diagnosis is king. X-rays are helpful sometimes, but not automatic. Okay, let's move on to management. How do we help someone with this? What's the approach?
The absolute cornerstone of managing Osgood-Schlatters is conservative treatment, non-surgical. That's nearly always the first line.
Okay, conservative first. What does that involve?
Several key things. First off, relative rest. That means cutting back or stopping the activities that really aggravate the pain.
So, modifying activity, not necessarily complete shutdown.
Often, yes, modifying is key. Then applying ice packs regularly to the sore spot can help with pain and swelling, maybe 15-20 minutes at a time, several times a day.
Right, ice. What else?
Short-term use of over-the-counter anti-inflammatories, NSAIDs like ibuprofen or naproxen can be useful for managing the pain and inflammation flares.
Okay, rest, ice, NSAIDs. The classic rice components, sort of. What else is in the conservative toolbox?
Physiotherapy is really important.
Ah, physio. What's the goal there?
It focuses on things like stretching tight muscles, especially the quads and hamstrings, and strengthening the muscles around the knee to provide better support and improve mechanics. It helps address any underlying imbalances.
Okay. And reducing sports participation.
Yes, often that's necessary, at least temporarily. Reducing the frequency or intensity. In some cases, especially if there is significant weakness in the quad muscle, a complete but temporary break from sports might be recommended to really let things calm down.
Okay. Now, what about surgery? You mentioned it's non-surgical mostly, but is it ever needed?
Surgery is really quite uncommon for Osgood-Schlatters. It's generally only considered as a last resort in cases where the pain is very severe and persistent, and importantly, only after the person has finished growing after skeletal maturity.
Only after the growth plates have closed.
Exactly. If surgery is considered then, it usually involves removing any problematic bony fragments, those ossicles we talked about, that might be irritating the tendon or causing persistent symptoms. This can sometimes be done arthroscopically, keyhole surgery, or sometimes requires an open procedure.
But again, that's rare. The vast majority get better without it.
Absolutely. The success rate with conservative management is very high. Most kids get better with rest, physio, activity modification, and time. Simple painkillers like paracetamol can also be used alongside NSAIDs or instead of them for just pain relief.
Any treatments that are generally not recommended?
Yes, it's generally advised against using corticosteroid injections directly into the area. There are potential risks associated with that, like tendon weakening or rupture. So, typically avoided.
Good to know. So, main message. Conservative care is the standard. Focus on physio and activity management. Surgery is very much the exception.
Okay, looking ahead then, what's the long-term outlook, the prognosis, and are there any potential complications down the line?
Generally, the prognosis is really very good. Excellent, in fact. That's reassuring.
It is. The symptoms typically get better and eventually resolve completely as the adolescent finishes growing and those growth plates fuse, usually in the mid to late teens.
How long does that usually take, though, for the symptoms to fully resolve?
It can vary quite a bit.
Yeah.
Complete resolution might take several months, but sometimes it can stretch out to a year or even 2 years in some individuals.
Wow, months to years. That can feel like a long time for an active kid.
It can. But the key is that the pain usually gradually lessens during that time. It's not constant severe pain for years. Now, one thing that might last is that bump.
Ah, the enlarged tibial tuberosity.
Exactly. A noticeable bump might remain on the knee even after all the pain is gone. Usually it's just cosmetic, doesn't cause problems, but sometimes it might feel a bit tender if they kneel directly on it.
Okay. And are there any more serious complications to be aware of, even if they're rare?
Complications are uncommon, thankfully. But they can include chronic, long-lasting pain that persists even after skeletal maturity in a small number of people. That persistent, prominent bump can sometimes be bothersome, as mentioned. And very rarely, you could get a complete avulsion fracture of the tibial tuberosity.
Where the whole thing pulls up.
Well, a significant chunk of it, yeah. That would likely need surgical intervention. But again, very rare. Overall, studies suggest about half of patients are fully recovered within 1 to 2 years. And like we said, symptoms nearly always disappear once growth stops, even if a non-tender bump remains.
So overall, a pretty positive picture. It's something that needs management and patience, but generally resolves well with time. Okay, let's try and bring this all together. Can we quickly recap the absolute key points about Osgood-Schlatters?
Yeah, absolutely. So key things to remember. Osgood-Schlatters is common, especially in active adolescents during growth spurts. It's essentially an overuse injury inflammation at the tibial tuberosity, that bump below the knee, caused by repetitive pulling from the patellar tendon.
Right. Pain gets worse with activity, better with rest.
Exactly. Diagnosis is usually clinical. Management is overwhelmingly conservative: rest, ice, physio, activity modification. Surgery is rare. And the prognosis, generally very good. It resolves as growth finishes, though a bump might remain. It's typically self-limiting.
Fantastic summary. You, our listener, should now have a really solid understanding of Osgood-Schlatters disease, the what, why, and how it's managed.
And remember, if you're on your MSRA journey and looking for more comprehensive resources and support, do check out passthemsra.com.
Loads of great stuff there. And for even more helpful materials, including free resources, don't forget to visit freemsra.com as well.
Yeah, definitely worth a look. And, just thinking about conditions like Osgood-Schlatters, it really underscores how important it is to understand these common musculoskeletal issues in young people and how effective relatively simple conservative management can be in supporting them and keeping them active in the long run. It's a good reminder of the body's ability to adapt and heal.